So thank you everyone for attending our STEAM webinar series. Today we have Dr. Andrew Sussman as our guest speaker. For those of you joining us for the very first time, I'm going to talk a little bit about the STEAM Network. We are a program that supports underrepresented minority scholars conducting or interested in conducting cancer health disparities research throughout the Southwest. We have 4 different institutions. We have Burrell, NMSU, NAU, and UNM. And we hope that you will join us for future webinars. If you are interested in joining the STEAM Network, I will put the link in the chat for you to check out our website. But with this, I would like to introduce our guest speaker. Dr. Andrew Sussman is a professor in the Department of Family and Community Medicine. He's the Associate Director for the Community Outreach and Engagement for UNM Comprehensive Cancer Center, and he directs the Cancer Center's Office of COE. He is also a multiple principal investigator of the STEAM project, working with Dr. Guest and Dr. Jimenez, and they oversee and direct the program from UNM. Today, he's going to talk to us about one aspect of his expertise, namely the community-engaged approaches and building community partnerships to enrich patient-centered research. And with that, I'll let Dr. Sussman share his screen.
All right, great. Thank you, Martha. Let me just go ahead and bring that up. Okay, hopefully everyone can see that. Let me know if there's any problems. Since we're a relatively small group too, please, I hope this talk is or can be interactive, and happy to field any questions as we go. I'm wondering if maybe, Martha, if you see any questions pop up in the chat, feel free to just jump in. It's always hard to do the talk and monitor. But yeah, as Martha said, I'm Andrew Sussman, and I'm based in Family and Community Medicine. Also direct this Office of Community Outreach and Engagement in the Cancer Center. A lot of the work that I do is community engaged, and we've given a lot of thought to those kinds of partnerships and the different ways that work evolves and the adaptations to those designs. And what I'd like to really spend some time today talking about is this approach to fostering community academic partnerships. And I'll use the acronym CAPS, or CAP, as a community academic partnership throughout the talk. So in terms of an overview, I'd like to spend a little time just talking about CAPS in health research, and the implications and why they've really increased in prominence, especially over the past decade. I'll provide an example of one that I've worked on actually outside of the area of cancer, but I think what's probably more relevant is the process and the approach to it as an example. And I think that'll give us some opportunity to think about the implications of these kinds of CAPS and ways that they can be helpful and relevant in our research, and then some concluding thoughts. So with that, yeah, let me get started. And again, please feel free to jump in and ask questions. So probably good to start with a definition of CAPS. So I would use this one here. I think comes from Hopkins Institute, that CAPS are collaborative relationships between academic institutions and community partners, and they can involve a variety of these kinds of partners or stakeholders, and of course be applied to a whole range of research topics. I like this notion that they're unified or characterized by a set of things that are relatively similar, which would be equitable control, especially with regard to stewardship of resources, that they should reflect causes and priority topics that are relevant to the community, and in fact, even community driven, that they have specific goals. They engage community members with a range of skill sets, but that ultimately they would have knowledge and interest of the causes of these issues, and academic researchers if it is a community academic partnership. So a little bit on some whys and whats. Why have they evolved and really gained traction, especially in the past decade or so? And I think a lot of folks would point to a failure of translation, that we have research findings that often are, we generate them in the academic setting, but we have challenges translating them into everyday or real world implications and applications. We need evidence of how to close this gap and better mechanisms to do so. I think it's fair to say that historically it's not been a common practice to tailor interventions to our marginalized and underrepresented communities, though certainly that has changed to some degree in the most recent period of time. And so community academic partnerships, CAPs, have increasingly emerged, and I would say in some cases are recommended or even required to improve awareness of health concerns, reduce disparities, and promote equity. What I mean by recommended and required, I think we can all think to different kinds of organizations or institutes or centers within our academic settings where, for instance, in our clinical translational science centers and our cancer centers, many of the requirements to conduct the work that we do involve the formation of structures to promote community engagement. And I give this example that you see on the bottom of an R01 FOA mechanism focused on community partnerships to advance research. So in that case, this mechanism is topically agnostic, but really calling for the use of a CAP to advance our knowledge base in a different health area. So a few other things, just touching on some of these principles, partnership principles involved in CAPS. And I think you would see an overlap here for those of you who may be familiar with community-based participatory research. I won't go through this list of principles, but I'm assuming many of these would look familiar to you in terms of the kind of mutuality, processes of building trust, reciprocity in particular. And I do want to highlight the figure on the bottom. We can think of this as a continuum in a sense, starting on the left from partnerships and forms of engagement that involve what would be the lowest level, which would involve informing or moving along that continuum to consulting. I think that we would aspire to be more along this right side of the continuum, right, in terms of involvement, collaborations, or higher levels involving empowerment. And so I think the goal here isn't to say that that if you're in that inform or consult end of the continuum, there may be study examples or initiatives for which that may be appropriate. But again, I think many of us are trying to move toward this other end of the continuum for these kinds of partnership processes. And I'll grab this CBPR conceptual model. Again, certainly attribute this work to Nina Wallerstein and her colleagues who have really done such extensive and important research in this community engaged research area. I think this model, again, I'm not going to go through all of the details here, but for those of you who may be considering a partnership or involved in one, I think the domains specified here are really helpful in terms of organizing efforts in those partnerships. We can think on the left of the context that all of our work is invariably embedded in, and we think about different kinds of partnership processes moving through that. And of course, they can involve different stakeholders and different structures. And then we're conducting interventional or other research approaches. And ultimately, we're observing or assessing the outcomes of that work. And so there's been a lot of thought here and really advancing the science of what kinds of forms of CBPR partnerships lead to beneficial interventions and outcomes. So I do want to evoke this, and I think is a helpful model that's influenced a lot of the work that we do here in New Mexico and certainly nationally and around the world. Okay, so I'm going to start moving toward this example that I'd like to provide, which is essentially a study, but mostly a story. And in this case, I'm going to talk about a study that was conducted a while back on traditional medicine or complementary and alternative medicine in primary care settings, and use this as a way to show the benefits and impacts of community academic partnerships in work. So, like to, you might be thinking, why am I staring at an apple? Well, I think, the metaphor I'd like to use here is that we often think about the fruits of our work, right? That these are the end products. We have data and findings, and certainly that's, that's what a lot of us are focused on. But I would argue that for the kinds of work that go into a community academic partnership, it's really all about the roots. And so we want to get to those fruits of our labor, but I would perhaps position us more in terms of building these roots. And I think in many ways, that's what this talk is mostly focused on. Okay, so let me start with a few things. First, in terms of feasibility, that CAPS exist along a continuum. I'll reference again that model that I showed before, that it is not a one-size-fits-all model, and that there is an important recognition of partnering throughout the process. So here we're thinking about development, implementation, dissemination, and beyond. I think it would be fair to say that a research study for which the academic team developed or identified the priority, developed the research design, developed all of the data collection tools and the analytic plan, and then went to a community partner to say, hey, what do you think about this, would not constitute the kind of CAP engagement that we're talking about here. So again, a different evolving and iterative nature of the work. And I'll apologize for the heavy use of gardening metaphors, but it sort of made sense to me as I was putting this together. So a few more things, the implications of CAPS on research, that it really does change and challenge in some ways the traditional researcher-subject relationship. I might say here that as a warning that CAPS may not be advisable for or could be hazardous to strict linear thinkers. I'm being somewhat facetious, but there is a need here, I think, in this kind of research to move away from very rigid designs of protocols and be open to adaptations that would naturally come about in the context of this kind of engagement. Okay, so the way I want to structure or have structured this this example of this project would be in these different ways here: what to do, how to do it, what it means. So sort of figuring out our results, and then what to do next and how to share it. So I'm going to use this as kind of a framework for moving through this example. So starting first, the what to do and the details around this community academic partnership. I want to point out that, and I'm not going to spend a lot of time on the details of these partners, but more to say that this took place in the context of a primary care practice-based research network that was led and really built here in the Department of Family and Community Medicine. It was called RIOSNet, Research Involving Outpatient Settings. It involved statewide clinician and community engaged processes to identify research priorities. A couple other elements of that structure involved a community advisory board, as well as a board of directors and other community partners throughout the state. So all of the work that was conducted in this network was really run through this community academic partnership. And so the last bullet there refers to this process by which we started to identify with these community partners, basically, what should we work on? What were the kinds of problems or concerns that were most relevant to our communities? And as you can imagine, a lot of different things came up. We needed to distill down over 50 options. And, one of the 10 priority areas that came up that was identified as being a key priority for this network was this one. So I'll refer to it as TM-CAM, so traditional medicine / complementary and alternative medicine. And what we mean by that here is for clinicians, especially primary care providers serving diverse communities in our state, there was a sense that they weren't connecting well with patients about their use of TM-CAM, and that they needed to do better, that there was a challenge integrating this traditional medicine approach with allopathic medicine. And in terms of our communities, there are, of course, varied experiences of use and a wide range of belief systems with regard to these. And you can imagine, and as folks presented, especially our clinical partners, a range of complexities and problems that could result from this disconnect, that patients could be having a preference or using other modalities of care for which the primary care provider may not be aware. And that could cause not only communication problems, but challenges in managing the care of those patients and their needs. So this emerged as a key priority in the network. So I want to, continue on a little bit with what to do. So as we started to refine this with contributions and perspectives from our community partners, we refined the mission and focus of this work. So how can we enhance this TM-CAM communication between patients and providers? And the challenge for us was to take this raw priority area and turn it into a viable project that met everybody's needs. Obviously not an easy topic. And so we developed an interest group. We had exploratory questions around, what's going on in this area? What do patients and providers want? So there was a series of interactions over time with these different community partners to ultimately develop the key questions around this priority. Okay, so turning a little bit more now to how to do it, that the what to do was, really the initial development of the priority, but these were really where some of the big challenges I think were seen. So we wanted to further refine questions and process through our clinical and community partners. We had, again, as I mentioned, a board of directors. These consisted of clinician champions from different health systems and communities around the state for feedback. They were interested in some of the clinically relevant topics, such as the potential to reduce adverse drug or herb interactions. And we had other community structures then to also look at this, the way that we should conduct the work. Community advisory board, multiple outreach visits around New Mexico. We also worked with the Navajo Nation IRB and the structures that are involved there, chapter houses and others that some of you may be familiar with, and consider them certainly partners in the process, as Navajo Nation members were part of our community advisory board. So how to do it? A couple other things came up in terms of this community feedback, which were really essential. And I want to get here into some of the ways that this community academic partnership influenced both the content and direction of the work. So we certainly were made aware of the sensitivities of this topic, and our community partners helped set boundaries of questions. And one of the things that came up, or in these two areas, that the study should not be about things like whether these modalities work. There was certainly pushback in terms of our exploration about looking at the efficacy of those modalities, as well as their context of use. And certainly among some of our tribal partners, it's not just about the use of a particular herb or other ceremony, but it's context of use, where it happens, how it happens, who participates. And the point I want to make is that we were certainly informed that these things would be off limits in the context of this kind of study. And that was certainly, those conditions were important for us to understand, and again, influenced the direction of the work we took. So here's a bit of a diagram, in a sense, a flow diagram of where we involve partner participation. So our research questions focused more on predicting patterns of this traditional medicine or complementary and alternative medicine use and processes of TM-CAM communication. And so you can see in the diagram then partner participation in planning. We worked on a pilot process, then data collection, moving into patient interviews and provider interviews, and certainly additional partner participation in the review where we developed clinician focus groups. So this was an initial starting point for us in the process of implementing this project, along with our partnership engagement and review. So taking a little bit of a detour here and starting with the pilot process, I'll kind of, and showing the sad state of the garden there, a couple comments on how not to do it in this case. And this was a really influential experience for us, and again, shaped the direction of the project. And I don't think it would have been as possible without our community partners providing guidance here. So we decided to test out some of the questions that we developed with patients at 2 different clinics in Albuquerque. And we spent the afternoon talking to folks about, again, their different use of TM-CAM and communication. And surprisingly to us, even though we were at clinics where we were told that the vast majority of patients use these modalities, nobody shared a single experience with us. And it appeared from the content of those pilot interviews that basically nobody used traditional medicine. And we assumed initially after that experience that we may not be asking these questions in appropriate ways, and it turned out we were right, which was a good lesson to learn. Otherwise, it would have compromised the entire project as well as the validity of our findings. So, just point to the idea of in our fictional minds that it would be a linear process, but the reality was much messier. So a couple things we learned from that pilot process was that our clinic staff partners were key resources, and they often are bridges between the clinics and the communities that, the clinics that they work in and the communities that they live in, and that we needed to speak with them about this topic and learn a couple things about how to ask it the right ways. So when we spoke to them, they confirmed that there indeed was very high use of traditional medicine among their patients, and they had insights into patient concerns. And one of the things we learned in that pilot process was that one of my colleagues, who himself is a physician, was asking patients some of the questions about what they use and how they use it. And our clinic staff advisors told us that, well, that's the wrong person to be asking the questions, because often patients won't feel comfortable sharing those things with healthcare providers. And so if you go out to clinics with an identified physician asking the questions, you may come up empty-handed, which indeed we did. So we did revise our approach. We structured ways to demonstrate further acceptance, and we changed the staffing and that team of who was asking the questions. So this led to a research design change that we hadn't anticipated. And we also included a component in the research design of having clinic staff focus groups as an initial step in every practice that we were going to conduct the study in. So that was not something that we had anticipated. And so, I'm just reflecting here, the clinic staff focus group piece in italics was a new piece added into our work. Okay, so what it means and what to do and how to do it. Let me move through kind of as we learn some of those key lessons. And we launched into the study and the data collection. one of the first things we did was to conduct this clinic staff focus group that I mentioned. And during the very first focus group of this kind up in a small clinic in northern New Mexico, we further learned an important lesson of the study, which again, I think would only have been possible through this context of a community academic partnership. And so the purpose of that focus group before we started talking to patients was to learn more about their local TM-CAM terminology, the clinic logistics, what were some of the cultural concerns of patients there that would facilitate our discussions with them. And so I conducted this focus group, and it consisted of 6 participants. And some of you may be familiar or have led focus groups. One of the things we often worry about in that dynamic is that there might be a participant who ends up dominating the discussion. And that can be challenging because, of course, in the goals of a focus group, you want to hear from everybody and distribute opportunities for insight across the group. And as we got started, it became very clear that this person was highly respected and was really dominating the discussion. And so I struggled with what to do about that. And as we continued in the discussion, it appeared to me that he was somehow shifting the focus of the focus group in a way that I had not anticipated. And I want to read this comment. This is a quote during the discussion. He said, quote, he was talking about herbs in the area, and the practice of the herbs was not an isolated practice. It was a very strong integral part of a system. Scientists have a problem understanding this. Researchers have a problem understanding this. And I have to say it, and I'm going to say it this way. If you take the part away from the whole, you're taking a part away from the whole for another motive, and the motive is usually to exploit it. If you don't look at it as an integral part of a lifestyle of the people, you're going to miss it. And we're going to end up with a beautiful, glowing report that's going to be false. So that was a impactful comment. That was something that I thought might be beyond initially why I was there. But as I started to realize that he was actually talking about me and my intentions, I did decide to let go and let him, in a sense, lead the discussion in the way that he wanted to. He started to focus on a particular herb called yerba mansa, which is grown locally in that area and used for different healing practices. And as we move further through the focus group, he specifically was talking about yerba mansa, and he said, so it's the herb that you take to calm you because it's for the heart. You have to be kind and gentle because it's for the heart. Even the name tells you that. And as we moved toward the end of the focus group discussion, he was sitting next to me, and about just before we finished up, he reached into his shirt pocket and he actually pulled out a piece of this dried herb. So he had brought it to the focus group. He was clearly intending to discuss it and use it. And with this last statement, he offered me the herb as the focus group finished up. And he said, so remember the name of that herb, okay? It means to be tame, and tameness comes in the form of gentleness and kindness. Be gentle and kind, but most of all, be sincere about it. So he was clearly commenting to me, and this really was an aha moment. And I should say that many of the comments he made were certainly more impactful to me because of the kind of relationships we had in our community academic partnership through different community advisory board meetings and other interactions. And so it was clear that yerba mansa, in his view, was a metaphor, that what I thought initially was an opportunity for me to gather a series of local terminology for TM-CAM was really an opportunity for him to evaluate my intentions. And he was a gatekeeper into that clinic. And I think if he assessed me to not have good intentions, I don't think we would have conducted the project in that clinic. And again, so we realized here a shift in researcher subject relationship. That I was not at the center of this interaction collecting data, that in fact he was collecting data, and it was an opportunity to assess the either go or no go status of this project in that clinic. So I bring this up as a way for the kind of understanding that it led to us, but also that, for all of us to be aware of these other stories going on, that there may be a broader context to these interactions than we may often think. And I include, we did publish a paper about this interaction with another community partner. I list that at the bottom of the slide there. Okay, so thinking now about that focus group interaction, what we learned from it, I think there's certainly something to be said for the practical results and the implications of that in our work. So we certainly were offered the opportunity to continue working in that clinic and others. We did learn some things about our TM-CAM terminology and clinic logistics, and we in fact had 100% clinic participation rate. Patients that we approached agreed to participate. The clinic was certainly very engaged with us. Again, I think if we had made some missteps that could have been due to not understanding these contextual issues in the partnership, we would have had a very different experience. So that participant in the focus group later served as a bridge to help us access patients. And as I mentioned, we had no refusals and ultimately very rich discussion. So we did see some of the fruits of that interaction in the conduct of the project. Okay, so moving a little through now, what to do next. We went out, of course, conducted interviews and focus groups with clinic staff, patients, and providers. Again, the focus of the talk today is not to tell you about this model of TM-CAM communication that we developed, but we did indeed work on that. That was a key outcome of the project. But in our partnership, we received guidance about looking at other ways to see if we got that model right. And they wanted us to review findings with our stakeholders. And we actually developed some videos with community members and then went back out to clinics to show them these interactions or some of the principles to see if we got it right. So you can see, again, growing this research design here on the bottom. We had interactions with our community advisory board, and then we did patient video reviews. And, on the left there in red, again, that research designs in the context of these partnerships are often dynamic and evolving and are responsive to input and emerging needs. And that, that does pose some benefits and also some challenges. Sort of jokingly, I looked up the most complex research design flowchart I could find on the internet, and but I being facetious, I don't think that the research doesn't get this complex, but obviously it does involve some different pathways that are unanticipated. So what to do next, and the last component, sharing. We certainly drew upon our community and academic partnership infrastructure to disseminate the results and gather feedback. That was a bidirectional process. We worked, of course, with clinician partners in this case through our board of directors and website and clinical outreach visits. There was heavy involvement and engagement with our different community partners, a community advisory board, outreach visits, multiple visits and different forms of interactions with the Navajo Nation. And then obviously the kinds of different audiences that would be more traditional for academic dissemination, including conferences and publications. So a couple of thoughts, wrapping up a little bit here with these kinds of caps and participatory results in the long term. It's, I think, essential to consider opportunities to maintain these partnerships. I mean, again, ideally, they're not just created and formed and managed in the context of one project, but rather sustained over time. And so that the projects themselves are not the endpoints necessarily, that the process of maintaining good relationships with clinics and communities and the ability to access other kinds of data, whether it's other priority topics of interest to those communities, or in the case of that vignette example I gave, I think being able to understand in the moment of that focus group what was actually happening was certainly contingent on that partnership and representatives from that community that we had engaged with for a long period of time. And so I like the idea in these of a CAP in thinking differently about the work we do, that it's a focus on creation of partners rather than subjects. I'm personally not a fan of the term human subjects in research. I think we should think about that differently. And that this kind of work is consistent with cultural and ethical norms. And again, a continuum as we think about different stages of involvement that again may be linked to the different purposes of the projects we do or the different levels of resources that we have to commit. So how you can do it, I recognize that there's probably a diversity of training backgrounds on the call and different positions of expertise. I think this kind of work is all about the roots. It's important for us to create collaborative teams. Who do you need to partner with? Or to take the time to engage with some kind of team or partnership that may already be established. I think about in our cancer center, we have a community advisory board. They can't be all things to all researchers, but they can certainly provide guidance and input and potential partnerships that could be nurtured for individuals. I think it's key for us in the academic space to be clear about what are our problems and goals, and then what skills and perspectives and interests and resources do our partners need. Again, this notion of reciprocity and mutuality of resources is really key, I think, to the maintenance of these kinds of partnerships. So a few thoughts on challenges and successes in these kinds of community academic partnerships. Often investigators themselves are not from those communities, and that certainly, again, if anything, emphasizes the importance of these partnerships and the trust building that must happen over time, and that certainly takes time to evolve. It's difficult to involve community members and partners in all aspects of the project. I mean, those of you, so many of us, for instance, see an announcement that comes out and it's due in 6 weeks back to NIH or some other funder. And we think, well, how do we do some of the foundational steps to engage those partners, have them review priorities and research design areas and get that done very quickly. So in some ways that speaks to the importance of having existing partnerships that are already in place. This kind of work, I think, can take more time. It can cost more. It may require having or already building good working relationships, as we're saying. And it does require flexible research designs that can often be at odds with rigid protocols and an evolving nature, therefore, of that process. On the other side, some of the successes here is that I think these kinds of CAPs prevent problems later, certainly in terms of trust building, engagement. Often the work that we end up creating, and in this case, the work and models that we developed around TM-CAM communication are more relevant and more valid with community approval and input. That was certainly the case here. I think it is just the right thing to do for a range of other sort of ethical and moral reasons, especially given the history of abuses in this area. And I put this on the other one too, but I think the evolving nature of the process can be seen as is a success, and an exciting aspect of research design as we're flexible to the needs and inputs of our community partners. So that is all I have. I just want to end with that picture of the roots. I did include on the left there some of the articles that came out of our research that we, published in collaboration with our partners. And I'm certainly happy to talk with any of you further about some of that work. And so, yeah, with that, let me come off sharing and yeah. Happy to field any questions or any comments about that work.
Well, I suppose I'll get us started if I may. Thank you so much, Andrew. I enjoyed that a lot. I guess I have a comment and a question first. My comment is, don't assume that you have a partnership just because you have a connection. I learned that the hard way. I'm at a medical school. I'm at a medical school, but not at a hospital. And so as I was doing a partnership study or starting a community-based study, we were working with some of our local hospitals with whom we have preceptors and students. And I assumed that we'd be able to just interact with them kind of at will and ran into some barriers of both having competing IRBs or at least dual IRBs. And also some limitations to participant recruitment on those hospital sites. So that was kind of a come to Jesus moment for me, I guess. My question then is, you talked about IRB specifically and how, can you talk a little bit about your process? How did you initiate that? I assume you had a single IRB with some agreements.
Yeah, so yeah, thank you. That's a really good comment too. And it is challenging sometimes to figure out, where a connection ends and a true partnership begins, right? And I mean, that's a subtle thing. In the case of the regulatory or IRB oversight, I mean, this project was, of course, based here at the University of New Mexico. So our IRB was the IRB of record. And along with other tribal communities, like for instance, the Navajo Nation has, of course, their own IRB process. So we did go through that. And that, for those of that may be another sort of discussion as well, but it really does involve a partnership in a certain way, given the local needs to go to chapter houses, to get agreements from service unit directors. I mean, there's a whole, sort of structured and sequential process to make it to Window Rock, of course, with those prior approvals. And then the obligations that you have to the Navajo Nation or other tribal communities about data ownership and sharing. I mean, for instance, all of the products had to get approved as well. And that's partly where, we talk about the additional time and engagement to make sure that we're meeting those requirements, along with the other processes that we had in place, our community advisory boards and so on, which I would say are not regulatory structures, right? We don't need to go to those folks in terms of IRB regulations, but again, it would be contrary to the conditions of the partnership to not have them review and provide input throughout the process. So yeah, I think that's a good, there's like different standards here, right, involved in this kind of work. I mean, the IRB creates certain obligations. Our partnerships may have others, and we have to be responsive to both. Yeah, thank you. Great. Anything else?
I have one more question.
Yeah.
Do you have any advice when conducting some of these focus groups on how to make sure that those quieter voices are heard and that dominant participant doesn't just take over?
Yeah, that's a good, I mean, I'll say sort of two things. I mean, in general, yes, we do want discussions, just like we would in almost any context that, don't only prioritize the voices of a few over, the full group, right? And sometimes that dynamic can be challenging. I will say in that example, it was sort of an exception to that rule, because I think if I had taken active steps to dissuade him from talking, I think I would have been in trouble, and I think I would have violated a certain cultural dynamic that was clearly at play in that room, and I think the other folks in the room would have been also in some ways offended if I had sort of shut him down to hear the others. So I say that as there's always exceptions, right? But there are techniques for being a good moderator in those situations. I mean, it's we've invited folks into those settings, so we don't want to sort of tell them at some point to stop talking. But there are, I think, subtle techniques to to walk around, to make sure, you can say to the group, I'd like to hear from everybody. You can ask folks directly to if they have additional insights or what they think. So, I think there's a bag of tricks that good focus group or even meeting moderators have to help facilitate interactions. But I guess the caveat, or the only thing there would just be to also be cautious about, or be attentive to the dynamic in the room, and maybe there's something else going on. In this case, I think there was. So I'll just, I'll say that. But there's a lot of materials out there to help support those kinds of equitable discussions. All right. Yeah, thank you.
All right, do we have any more questions? I'm going to go ahead and share my screen again. I'd like to thank our guest speaker today for giving us a wonderful talk, and everyone else for participating and hearing. At this time, I do want to remind you to please complete the evaluations that we have for today. There is a QR code that you can scan. I will put the link in the chat, as well as sending you an email with an invitation for that evaluation. It will be open for 72 hours, so please complete it to help us. And just a reminder for our future webinar series, we will not have another webinar until September. At that point, we'll have a couple of speakers from the American Cancer Society talking about priorities and funding opportunities for New Mexico. But in August, we are having our annual summit. So please be sure to register and participate. I will share that registration link as well. But if you have any questions, please let us know. If not, I'd like to thank you again for being here on today's webinar.
Thanks all. Bye.